channel.
Hi, and welcome to another episode of Ask on CYC. So we have a very special episode for you today, and it needs no introduction. We're giving you the opportunity to ask a doctor, and that's the topic of tonight's show. Ask a doctor any question you want. Sky is the limit. So take the number down, please. The number is 0416 551 292. You can ask as many questions as you want. This is your opportunity to ask while being anonymous. If you're too scared or too embarrassed to go to your local GP, here's your opportunity tonight to ask a question in terms of the medical department. So please feel free to send in your questions, give us a call. If you want to be anonymous, you want to tell us who you are, you're more than welcome. So let's kick off tonight's show. We have a very exciting episode for you tonight. So I would like to introduce you to our guest on tonight's show. We have with us Dr. David Youssef. Welcome to the show.
Thanks, Mina. How are you?
Good, thank you. So you work in pediatrics, so you deal with children mainly.
Yeah, so Children's Hospital, Westmead.
Okay, so I prepared some questions until the audience get involved and ask the questions. I'll only put a few of them in terms of pediatric topics, but the rest of the topics will be just general GP related topics. Okay. So let's get the show started. Okay. So I want to talk about the common cold. Like now we're in winter here in Sydney, in Australia, and the cold it's increasing. So there's a high possibility of people getting the common cold. Yeah. Is it necessary for people to go to a GP, or can they just go and treat it on their own without visiting their GP for this?
So usually with the common cold, we just use conservative measures. So we ask people to take analgesia or paracetamol for pain or temperature. In terms of like fluid intake, that's the most important. A lot of people lose their appetite during that period. And so after that, we suspect that most of them usually have symptoms which they can treat just with over-the-counter products. So sore throat, we tell them to gargle things and have lozenges and have hot fluids. But most of it is just rest and conservative management. In addition to that, what we do is we try to preempt the flu season by giving them and encouraging the influenza vaccine, especially in the winter months for most of the ages. And then the idea is to reduce not the common cold, because you can still get the common cold even if you've had the flu vaccine, but the idea is to stop influenza virus where we know that there's complications from it. Okay.
Because with me, when I feel a cold coming on, the first thing I do is I run to my nearest drugstore chemist and I buy a bottle of vitamin C and I buy cold and flu tablets, but I always choose the one with pseudoephedrine in it, which is behind the counter, which they ask me for my ID when I come to buy this. So why do they ask for the ID, and what's the difference between taking the cold and flu tablets with pseudoephedrine and the ones without pseudoephedrine?
So previously, pseudoephedrine was used to basically as a precursor for speed. So we know that it belongs to the same family as amphetamines. So they used to basically distill the cold and flu tablets. They could purify it and then obtain pure, what was basically equivalent of pure amphetamines, and then sell that. So they've made it a little bit more trickier now because they've added things to it like cough suppressants, paracetamol and other additives, with the idea that even if they do distill it, then they can't get pure pseudoephedrine. So the new agent, which is another decongestant, is unrelated. It doesn't have the same effects. It doesn't give you the same kick that you'd normally get with pseudoephedrine, and you don't feel like, despite the fact that you might be fatigued, you don't feel like you have the energy to continue. So some people, swear by one over the other, and the idea is that the government's trying to control how much is actually disposed, so that how much is available on the street becomes less.
Okay, so that's why they've recently started asking for ID.
Yeah, okay. So they put it in roughly about 1 to 2 years ago when they found that people were using it for, recreational drug use as opposed to its pure effects, which is, for cold and flu-like symptoms.
Okay, very interesting to hear that. All right, so let's move on to something completely different. So with women, how often or at what age should they start getting a mammogram screening?
So most women, it's usually between the ages of 50 to 74. And the reason we say that is because before that, there's a lot of breast changes that occur in young girls. And a lot of girls will notice that they have they feel lumps, especially during their periods or during their menstrual cycle. So what we say to girls is, if you feel a lump and it feels unusual, doesn't go away with your cycle, it's still there, it's sore or feels rock hard, then definitely go see your GP, because then it'd be something that we'd need to watch a little bit closer. And then once that happens, once the age of 50 comes upon you, basically every 2 years we suggest that you do a mammogram. And the idea is that depending on what the family risk factors are, so if there's someone else in the family with breast cancer, or if there was someone diagnosed at a younger age, or we know there's a genetic component, then we usually screen a little bit younger than that. So sometimes we do have girls that are screened even younger than 50, and we say to the girls, be vigilant and know your body. And if you feel something's not right, then definitely act upon it.
Okay, so let's now look at the male side of things. How about prostate examinations? What age should a man get his first prostate exam?
So the prostate is a little bit trickier, because obviously in terms of being able to access it, it's in terms of position-wise and where it is. So for men, it's usually where they've got a family history of prostate cancer is the most important thing, but usually it's the symptoms that they get. So in terms of their urine stream, the flow, how frequent they go, if they find it like it's almost difficult, like it's almost like trying to pass urine through a brick wall basically, or the stream is not there, or they basically it tatters on their shoes, then we say, look, there might be something going on with your prostate and get it checked. And for the men, it's a little bit difficult, because you've got to examine them at the same time as do a blood test. And even on the two together, you may or may not know whether there is something going on with the prostate. So anyone that's really concerned, like usually we say, 50 is this magical number that we've come up with. But, if you do have it less than that, then we say, okay, if you're worried, then definitely see your GP. And then he can start, the ball rolling.
Okay. Just a reminder to our viewers, please, this is your opportunity to ask a doctor whatever you want to ask and remain anonymous. So the phone number is 0416 551 292. Look, I have prepared questions for tonight's show, but I don't want to ask any of my questions. I want to hear what you guys have to ask. So please send in your questions through text or give us a call and speak to Dr. David on tonight's show. Thank you. So I want to ask, in terms of antibiotics, which is prescribed for a lot of things these days, is it, in the long term, is it bad for us as it kills the good bacteria?
It's a little bit tricky. So the short-term answer is yes and no. So antibiotics kill the bacteria, a bacterial infection that you have on board now. The problem is trying to work out which antibiotic to give for the infection you have now. And sometimes you can't identify a bug, so therefore you treat appropriately. So you basically cast the net out wide with the idea that you basically kill as much as you can. The problem that happens is bugs get very clever very quickly. So if they realize that the same mechanism is used every single time, then they find ways of escaping it. So we have now a problem where they become resistant. So it doesn't matter how many antibiotics you throw at them, they don't respond. So kids, adults will be sicker for longer, or what used to basically recover won't recover anymore. So especially in, like, for example, Northern Territory, where we know kids get infections that usually kids in Sydney shouldn't get, they basically die from infections because of the fact that the kids don't get the antibiotics, and when they do get the antibiotics, most of the bugs are actually resistant to it by the time they get it.
Okay, so if we become resistant to a certain type of antibiotic and our doctor still prescribes it to us, should we inform them so they can maybe prescribe another form of antibiotics, or it doesn't make a difference?
Yeah, so I mean, it's definitely a valid point. So if you feel like you're on something for a treatment, say for example for a chest infection or urine infection or something, and it's not actually getting better, it's actually the same or worse, then you definitely need to go back, because it means either, number one, the bug may not be responding to what you're on, or number two, it may just have developed a way of overcoming your treatment. So it means that you've got to readjust what you're doing and reassess it. It may not be the actual source of the cause of the infection, and you might have, sometimes you can have a collection, and so the idea of if you have a collection that's walled off, you need to basically get it out. So sometimes we do things like where we've had, knee joint infections, things like that. The most appropriate thing would be to get the pus out or get the abscess out or remove the fluid and then give the antibiotics. But if you give antibiotics just on the first go, it won't work, because it just physically can't get into those spaces.
Okay. So living in Australia, where Australia has the highest rate of skin cancer, So this question is probably one of the most important questions I'll ask tonight is, if a person has a spot or a mark on their body that they're, worried about, should they get it checked up?
Definitely. So, I mean, the most important thing is usually we're taught always the ABCDs of skin. So the A stands for appearance. So if it appears that that spot or that mole or whatever it may be looks distinctively different to the other skin or other spots in your body, then definitely it's one thing to flag. If the border of, and so the B stands for border. So if the border is a bit unusual, it's not very, well circumscribed, if it looks a little bit jagged and there's, a different color to it, so that's the C, and the diameter of it is a bit too big, like the edge of your pen basically, bigger than the edge of your pen, then it's definitely something that needs to be looked. So we go through the ABCDs because we look at one spot and we say, okay, that spot where you're getting exposed to sun, especially in things like builders and contractors and people that are doing lawns and things like that. I mean, we're very poor at doing, sun protection. And especially living in Australia, and if you're in the sun between 10 and 3, we say try to minimize your risk of skin cancer by having those protective things, sunglasses and hats and things like that, especially if you're at the beach. But most people will kind of avoid them because they're trying to work on tans, and a tan is a good thing, but skin cancer is not a great thing because the treatment for it it's intense, and you don't want to be left with skin cancer because you've got an awesome tan.
Okay, so can you just go to your normal GP to get it checked up, or is there someone who specializes that in this area that we can, instead of wasting time and going to a GP, that we go straight to that person?
So most of the GPs are trained to actually have that in their kind of kit, in the sense that they know what looks sinister and what looks benign. And they're usually your first port of call. Following that, they usually refer you to a dermatologist or a skin clinic of some sort. So because sometimes what happens is they'll actually do biopsies of it. And so that's ideally what's the most confirmatory way of working out if that skin condition is a malignant condition or if it's benign, and you can be left alone.
Okay, that's very, very useful tip. Okay, so let's talk about snoring. I know it's a big factor for a lot of people. Is it dangerous to our health if a person has a heavy case of snoring?
So it's a little bit tricky in the sense that snoring on its own is a phenomenon that we know that basically because when you're asleep, everything gets floppy. Your muscles in your neck and your airways get floppy. So if you add a lot of insult to that, so if you add, for example, large tonsils, if you add a floppy airway, if you add the fact that, for example, in children, we know kids with Down syndrome, or if you tend to be obese or overweight, that can definitely all contribute to snoring. So if you do have snoring, we know that if you have pauses in your breathing at night, if you stop breathing, if you choke, so if you wake up in the middle of the night and you get broken sleep because of your snoring, it definitely has an impact. So you'll find that these people are most likely to be irritable during the day, their concentration's off, they're not as alert, they need to sleep smaller periods more frequently, they'll sleep on 5-6 pillows, they'll sleep propped up, even sitting up, because the idea is to increase their airway diameter to avoid them from obstructing their airways. So if they snore and they pause in their breathing, it can definitely have an effect on their concentration, their heart, their lungs, and everything will fall into place because of the fact that one component's not actually delivering enough blood and oxygen to their brain.
So a person who snores, does that necessarily mean that they're getting less oxygen while they sleep than a person who doesn't snore?
Yeah, so if they're pausing during their breathing, or if they stop breathing at any point in time during the sleep, during that period, they're not oxygenating their brain. So it's not unusual to kind of pause for a couple of seconds, but if you're pausing for prolonged periods of time and you do it repeatedly throughout the night, those periods are definitely periods where you might have blood to the brain, but you might not have oxygen to the brain. And so you can be seen at, your GP can send you to a sleep specialist, and what they'll do is like a sleep study. They record you, they put these intensive dots all over your head, all over your body, and they watch your breathing, they watch your chest movement, and then they watch what you do. Do you pause, do you stop, do you snore, and do you choke? And if you choke, then they go looking for why. So some people suffer from, like with allergies and allergic rhinitis and large tonsils, then you can correct a lot of that. Some people unfortunately need things like oxygen overnight, and so we call it non-invasive ventilation, where basically we force the airway open. So even though it's going to collapse on itself, we force the airway open. So the idea that they oxygenate their brain.
Okay, so a person who has a heavy case of snoring, do you recommend that they should seek treatment for this?
Yeah, especially if, and most of the people that are brought to attention is actually through a partner. So it's either through a sibling, a brother, can be on a school camp or Sunday school camp, and someone will say he really snores, like he almost chokes during his breathing or sleeping. So they're the sort of people that you want to definitely refer to a sleep specialist, because then they can make a big difference. Because you can break up a 10-hour sleep into 2-hour intervals. Well, then you can correct that. You can definitely correct that.
Sure. Okay, we just got a question that just came in from an audience member. They're asking, what are your thoughts on surgical procedures that help you lose weight, such as the band or the sleeve?
Okay, so the bands and the sleeve have indications. There are certain indications where definitely it's something that needs to be explored with people that are morbidly obese and where there's a clinical indication. If people are doing it for cosmetic reasons, the problem is that you can get into surgical complications from the actual procedure. So a lot of these procedures, the idea is that you remove sections or components of your stomach or your bowel. So a lot of them with the bands, what they do is basically tighten the area or the capacity of the stomach to obtain food. So if you make it physically smaller, and you have a large meal, then you basically physically vomit. So it's like someone physically compressing you. From the lap, they're the lap bands. So the resections basically, or the sleeve, they basically cut off a segment of it. So those segments are full of nerves. They're full of channels that are responsible for basically digesting food. So you got to realize that at that point, you're not going to digest that food. So you'll lose weight rapidly. The problem is that weight loss comes at a cost. So you'll lose your fat in your arms, your fat in your face, and you become very almost cachectic. So because you can't lose that weight physiologically that quick. So you'll lose protein, you'll lose muscle mass. And so a lot of people that have these procedures end up on nutritional supplementation, what we would give to basically our kids when they're trying to gain weight because they can't afford to lose weight. So they supplement these people that have had these surgical procedures to stop further weight loss, because you need a kind of a stop button to make sure if they keep losing weight, then you're in trouble. So there is a benefit to them in the right patient. The problem is in a patient that's just overweight, who's not tried, for example, physical exercise, who's not tried a really diet, who's not tried other measures, it's kind of it's almost the be all and end all for some people. They're like, this is the quick fix. I just get the surgery, I lose my weight, and then my life will be better. And it's not, because it comes with its own risks that forever else you've got to be constantly monitoring for.
So this procedure should be the last resort after trying all these other methods of losing weight? Because I'm seeing a new trend these days of a lot of young people in their early 20s who are getting these procedures done.
Yeah, so if it's for cosmetic purposes, it's definitely the last resort, because you do not want, a 20-year-old having sections of their bowel cut out or their stomach in the component of trying to lose weight. If it's basically clinically indicated, so you've got a person who's morbidly obese, who's snoring, you've got heart disease, diabetes, and all the complications of underlying illnesses, then definitely that's something that needs to be explored. And a lot of them have long waiting lists now, because a lot of people have caught on to the aspect that if I can get it done privately, I'll do it privately, I'll lose weight, and I'll be fit and healthy, and I can go into my six-pack and then work out. But the problem is then they got to control their diet and their intake and their protein and their carb intake, because you can't then just eat whatever you want and expect to lose weight because you've got rid of 50, 60, 70 kilos. So it's difficult because people think it is the quick fix, but it's not the first answer. Like most people will have a gym membership, but if you ask 100 people how many times have you gone to the gym with last month's membership, you probably get 5 or 6 visits, and during those they're not getting high intensity sort of periods. They're getting, they went to the gym, they sat on a treadmill, or they jumped on the treadmill for 10 minutes and they walked out and they were exhausted. So, and that's the tricky part, that you need basically a graduated program. You need someone and that's why all these boot camps and things like that have increased, with the idea that someone is watching you while you're doing it.
Yeah. Okay. I know with the ring, the lap band ring, I know that you can always enlarge it and always shrink it according to what you feel at the time. And So if you're saying that if when they lose rapid amount of weight and then they're losing all these nutrients and all these protein, then they can just go back and enlarge it?
Well, it's tricky because you're actually putting a physical band on it. And the problem is sometimes the band slips. So the band can slip off. And so you basically start eating normal food, and before you know it, either you start vomiting because it won't physically go down, or you start gaining more weight because it's basically slipped off what it was supposed to do. So imagine a pipe and then someone ties a ring around it and someone's constantly squeezing it, and then you finally let go of it. The pipe is just going to go back to its original size because it takes the easiest path basically.
Okay, very interesting. We're going to go for a quick break, and when we come back, we'll continue our discussion. Just a reminder to our audience members, this show is for you guys. Please, the opportunity to ask a doctor whatever you want. There's no limit, and you can ask as many questions as you want. The phone number is 0416 551 292. So please send us a text or give us a call and speak to our doctor on the live show tonight. Thank you.
CYC, Christian Youth Channel.
Hi, and welcome back to Ask on CYC. On tonight's show, we're giving you the opportunity to ask a doctor. So you can ask whatever you want, and you can ask as many questions as you want. So please, the phone number is 0416 551 292. The opportunity is in your hands, and you will remain anonymous when you ask your question. So please ask a doctor on a live doctor on tonight's show. So let's get back into it. So until the audience send in their questions, moving on to the questions I've prepared is cholesterol. What are the dangers of having high cholesterol?
So the cholesterol, like naturally, your body produces cholesterol, whether we like it or not. Okay, so usually most of the cholesterol is produced between 11 p.m. and 3 a.m. in the morning. And that's why we say if you're going to have your heaviest meal, don't have it then. So don't have it at 10:30, then go to sleep, because your body's going to naturally produce cholesterol because it needs it to produce steroids to bulk up your muscles, for protein, for muscle metabolism, for a lot of things. So cholesterol itself naturally is a good thing. The problem is when you have high cholesterol, if you have a garden hose, and if I start filling the garden hose with little pebbles, the amount of water coming out from one end will start to reduce gradually. If I then start putting more pebbles or bigger rocks, at some point, there's going to be no flow from the other side of the hose. And that's what cholesterol does. Any blood vessel to the most important organs, obviously your brain, your heart, your kidneys, your lungs, all these vessels are dependent on good blood flow. So if I start reducing your blood flow to your heart, you can end up with chest pain and a heart attack. If I reduce it to your brain, you end up with strokes and embolus or complications in your brain. So if I do it to your kidneys shut down. So the problem is that these little, almost cheeky but also helpful things that are supposed to assist your body make it difficult, because if you have too much of it, it's not a good thing. And if you have not enough of it, you're not going to make enough for your natural synthesis. So in terms of cholesterol itself, is it a bad thing like in a normal individual with a good diet? No. Is it a bad thing at the extremes? Yes, because you've got to work out at what point do you stop it? At what point do you, a lot of the cholesterol medications, what they do is basically put a plug on where it is. So your most common one will actually just put a plaque on the top of it with the idea it just stabilizes it. It never actually gets rid of it. It never actually breaks it down. It never dissolves it, because you physically can't, unless you take out that blood vessel and put a new one in there. That pipe that's it. Like that pipe is not going to change.
Is it possible to have low cholesterol to the point where it's actually not good for your health?
So you can have a low cholesterol, and the problem is it may be captured. Basically, it's being made by the body and it's building up. So we know there's a number of liver diseases, and some kids do get it and some adults do get it, where basically it's made by the body, the liver's sitting there churning this cholesterol and just gets captured into these fat cells, and it's got nowhere to go. So the liver gets bigger because if you block the liver, fluid in their abdomen, and then you wonder why the child looks so malnourished or got malnutrition, and it's because of the fact that he's making it. It's just it can't get out. So having low cholesterol and having high cholesterol at both extremes is bad. Anywhere in between, and this is the happy medium that we talk about, is where ideally you want to be.
All right. So on that, and get a blood test, just a regular blood test to check up on the iron, cholesterol.
So if you were otherwise healthy young man or young woman, and you're between your 20s and 40s, and there's no real family history of heart disease, lung disease, kidney disease, you could do it anywhere between every 3 to 6 months. And then at the 6 months mark, if everything is perfect, then you'd say, stretch it out for another 6 months. And you might just do a physical exam and check on the patient and make sure everything is okay. If there was any indication to do it before, say for example, if you had a young guy who was in his 30s, 40s, and a strong family history of heart problems, strong family history of diabetes, people dying at a young age, for him you'd be a little bit more aggressive because of the fact that he's the sort of person where if he has a heart attack or if he has, complications, you don't want to leave him out 6 months before you say, okay, let's do something about it now. So he would be the sort of person where you might see him once every month, but he might do a blood test once every 2 or 3 months.
Yeah, but isn't say a person? I say I do it every year. Sorry, and I know when I go and ask for my doctor to get a blood test, he always tells me, "Why? You're young, you're healthy, and you don't need to do it once." But you said every 3 to 6 months, isn't that?
So the blood test itself, you might not do every 3 to 6 months, but at least as a baseline to say, okay, this is where you are now. These are the things that are normal, that we know are normal. Okay. So your iron levels and whatever are all normal. Sure. And in 6 months' time, we're going to have a look at you and see how you're going. If, say for example, if you went back to your GP and you're like, for the last 3 months, I'm increasingly exhausted, I can't sleep, I can't eat, I'm losing weight, he's definitely going to be, there alarm bells where you're like, this is not normal for a young man such as yourself. Right, we're going to do a blood test at this point. And then at that point, he'll compare it to what you had done 6 months ago and say, okay, there's been a change or it's exactly the same. It might just be...
Okay. All right, so I'm going to start throwing some questions at you in your field, in your line of work. So let's talk about children. So how can we test what our child is allergic to in a safe manner?
Okay, so most children that we test are done in a supervised environment because ideally what you want is an immunologist or an allergy specialist to be doing the testing. And what we normally do when we do skin prick testing, for example, we get multiple samples and we mark them on the child's skin and then we compare it to salt water. Because some kids react to salt water, so we have a baseline for what they react to and then we compare it. And the idea is that we have medication on board ready to go if the child develops anaphylaxis. So if they have an allergic reaction, we have adrenaline ready and we're going to give the child adrenaline because that's really what you want. The problem is that some kids get exposed to allergens very early on. So if they go to a birthday party, if they go to school or something like that and they have peanut butter for the first time or they have something else and then nothing really happens the first time and then on a subsequent exposure they have another peanut butter sandwich or something and then they swell up immediately, then really what's happened is they've really actually had a real allergy test the first time. No one actually picked it up because it just looked a little bit unusual. And then the second time they've actually had they've developed the allergen or an antigen. It's ready to go. It just needs one more insult and then you get the full florid response. So for parents, we say, if you're worried about it and if you suspect there's an allergy, definitely get your GP to refer you to an immunologist or an allergy specialist and they can do the testing. And it doesn't have to be, within your local area. You can go to the hospitals, they can set up a clinic day, but there definitely needs to be supervised because if there is something that goes wrong, you need to be able to act on it quick.
So a parent should never try it at home and say, here son, try some peanut butter just to...
Well, I mean, if they suspect that the child is allergic to peanut butter, testing it like that is dangerous because you've only got 15, 30 minutes before your airways block off, before you lose, your heart rate and your response. So you really don't have, it's not one of those things where we say to parents, don't go to, XYZ clinic and test it at home. Make sure that someone's testing it for you and they're watching the child the entire time.
Okay. We just got a question that just came in relating back to, we're talking about blood testing. So yeah. The audience is asking, how often should I get checked for STIs?
Okay, so with sexually transmitted diseases, this is a little bit tricky because most of it is asymptomatic. So most people walking around with your common sexually transmitted disease, gonorrhea, syphilis, chlamydia, 60 to 70% will have absolutely no symptoms. Okay, when they do get symptoms, it's usually with new partners, usually once they get married, or with girls, usually it's where they fail to fall pregnant. Okay, and because for them, the complications of sexually transmitted diseases are much more severe. So if a female and or male notices abnormal discharge, pain in the groin, pain on, on intercourse, or if they're basically not themselves in terms of urine and bowel output, then they're the sort of things where you definitely need to be tested. And most of it is actually swabs. So most of it, the GP will say, here's the swab, go in the toilet, do it yourself and come back. And where kids or adults or, adolescents have refused, then we can do it on urine tests. So you can do it mostly, get them to pee in a jar and you send it off and you can still get the same results just as quick.
All right. I got another question that just came in from an audience member. This is actually a very interesting question because it's becoming a very big trend. Have you heard of the HSP, the halal snack pack?
No.
So the halal, I'll explain what it is, then I'll ask the audience question. So halal snack pack is where you go into a kebab store and you ask for the snack pack, where it's a layer of chips, layer of cheese, layer of meat, whether it's beef or chicken, then your choice of sauce. So that's what the snack pack is about. So the audience member is asking, what is your view of the new trend halal snack pack, and how bad is it really to consume that much? So let me add on to what the audience member's asking, just to get you familiar with it. There's a page on Facebook dedicated to this snack pack where there's been people who have said they're going to do the snack pack challenge, where all they did eat for 5 days straight, breakfast, lunch and dinner, was this snack pack.
Yeah.
Which I thought it was just ridiculous. So going back to what the audience member's asking, is it really bad to consume that much meat?
So that much meat and that much fat in a short period of time is not going to have, the complications of, if a person who's otherwise fit and healthy, by the end of the week they'll feel sick, definitely feel sick. Will it drive up their cholesterol? 100%. Will it do it quick enough that they'll get complications from it the following week? Probably not. But in terms of nutritionally, what you're doing, basically you're driving just fat, pure fat into the cells, and you're asking the body to cope with it. So it's similar to, when you go to the kebab store or Euro store and they do the meat, they put the chips in it, they put the feta now, and all these, the Greek style of eating. The reason the Greeks actually do really well in terms of their diet is not because they eat that food, is because the Mediterranean diet is olive oil and lots of vegetables and, lots of fresh things. They don't have, it's not fried. And the problem is not in the actual snack pack or the cheese or whatever else is in there. The problem is that you're putting carbs, starch, fat and protein all in one, and then you're saying to the body, okay, you're not used to this quantity, you're not used to this amount, I'm going to give it to you 3 times a day, I'm going to give you this assault for 5 days a week, and then you deal with it. It almost sounds like the Super Size Me challenge, where that gentleman that did the movie, he did it for 30 days. And by the end of 30 days, he'd gained weight, his cholesterol went through the roof, and at one stage, I think the doctor said to him, you're likely to drop dead if you keep going. So if you did that for 5 days and thought, this is okay, and then kept going, then at some point, your blood vessels are going to say, look, there's way too much cholesterol here. And so what it does, when your blood vessel gets blocked, similar to your garden hose, it starts making smaller blood vessels. But these smaller blood vessels can't deal with the pressure, can't deal with your heart. It's trying to compensate as much as it can. And so your heart just starts, and if your heart compensates, then everything else falls into pattern. So your kidneys will fall into pattern and compensate, because they're saying, look, there's less blood, so let's shut down the blood supply to the kidneys. Let's shut down the blood supply to the brain. And so you're more likely to get strokes. You're more likely to get a lot of kids where they're on these high-fat diets because of illnesses. We actually force them to basically eat this equivalent because they lose weight despite the fact that we give them fat. So with some conditions, you have to force people to eat something similar to that. But when the condition doesn't need it and you have a purely normal individual eating this, then the effect is,
It's actually become a very big trend now these days, and it's moving all over the world. So a lot of youth are getting into this trend where they frequently eat this meal. I probably eat this once a month, and I feel how heavy it is when I do eat it. So I don't understand how people do this frequently.
Yeah, and I'm sure after you eat it, your level of function is actually reduced. There's no way your body, because your body has to realize and has to pick up the fact that there's so much food, there's so much dense food that needs to be broken down quickly. So it redistributes all the blood supply to your stomach and your bowel. And so you'll feel increasingly lethargic. So the compensation soda of some sort or something to keep you going, you drink more coffee, you tend to drink more things or have more snacks just to compensate the fatty food because it's so much dense food. Your body's like, this is not normal. I can't continue on this, but you know what? If you want me to do this, I'll do it.
Okay. Just a reminder to our audience member, please, if you have any questions you want to ask a doctor on tonight's show, the phone number is 0416 551 292. This is your opportunity to ask while being anonymous, and you will never know the answer unless you ask. So moving on to the next questions, I want to talk about, still on the topic on children, vaccines. Vaccines have become regulated by the government now. So what should a child, any recommendation, should a child be up to date with his vaccines, or is there some vaccines that are not necessary, or should we all follow by the government's regulations?
So there's two schools of thought, Mina, in terms of vaccines. There are people that are willing to take the schedule on board that they get when they have a newborn, or the blue book that they get when they're all delivered in the hospitals, and they say, okay, I'm going to go through the schedule and just follow the schedule, and I'm not going to deviate from the plan. To the point where the government's actually released apps for doctors, for parents, so that they know they get a kind of SMS or an email saying, right, you're ready for your next vaccine. School of thought is no vaccines, they'll list them. The problem is that these are basically preventable diseases. So we know that vaccines can cause side effects from the perspective of it does cause you to have, pain in your arm, and it can cause you to have a fever, and it can cause you to have, a common cold still. Even after the influenza vaccine, you can still get a common cold. You can still get a runny nose, you can still get fever, you can still have that, but you won't die from influenza because you've been covered by the most prevalent of the influenza vaccine. The problem is if you have someone who's, for example, who's got cancer, for example, a person who's got immunosuppressants, and they live with a child who doesn't, or someone like the rest of the family, they can't afford to get sick. So the rest of the family has got to be super vigilant and vigilant in the sense that they basically have to be vaccinated themselves on the off chance that this child doesn't get any of the preventable diseases. So we call it herd immunity. So basically, if I vaccinate everyone in the room, the child that can't afford to be vaccinated because of a condition or because of a reaction or because of a side effect, well, then he's covered by the fact that everyone else will not be able to give it to him.
Yeah. All right. I got a hypothetical for you. So a mother and a father on a gluten-free diet, and they want to start their child to be on the same diet. What would you say to that?
So this is a hard question because we only recommend the gluten-free diet to children or adults with celiac disease. So if there's no celiac disease history, then there's no point. So if it's for, feeling and how they feel and how they go about their daily business, the gluten-free diet is just an expensive diet then. Okay, so you could have a vegan diet, you have a vegetarian diet. All of these are just expensive diets if the child does not actually need it. So if there's no family history of celiac disease and the child's actually never been proven to have celiac disease, then there's no point in putting them on an unnecessary diet because the gluten-free diet is actually quite stringent. You can't have any barley, you can't have any rye, you can't have any wheat, you can't have any oats. So if you think about it, you can't have a normal sandwich. So if you go to a party and everyone's eating fairy bread, you can't eat it because it's just wheat. So it makes it hard. So if you say to a parent, look, I'm going to put you on this diet, it basically means lifestyle change for everyone, not just the parents, but the child, as well as his social interaction, because it makes it hard for a child to be able to, just be with his friends normally.
But is it necessary for a child to get his gluten intake?
Yeah, so they should have a balanced diet. They definitely should have a balanced diet, and they should be varied. So it shouldn't just be one particular food. I know a lot of parents say things like, I don't give my child milk when they have, I don't breastfeed him or bottle feed him when they have diarrhea, for example. I'm like, okay, so what do you feed him instead? They're like, nothing. So you can't give a child water because it won't be absorbed. So you can give them small, frequent amounts of raw milk if it's just to appease them, basically keep them comfortable. Ideally, you're rehydrating them, but if it's just to keep them comfortable, then you've got to give them something. But you can't put them on, boiled water and think that, this is going to treat, for example, diarrhea and vomiting.
Okay. We just got a question that came in from an audience. They're asking, can sleeping next to your phone cause cancer due to the radiation?
So this is a really good question, and there's a lot of research done saying now that we know level or beside your phone, there is radiation from the phone. We know that. That's not deniable. No one's going to ever deny that. But whether it causes you cancer, we know that it definitely reduces, you can reduce the risk of brain tumors and brain phone at a different level. So what we say is, if you're sleeping at a 1 meter height, for example, have your phone beneath you. Okay? Not at the same level. Don't put it on the pillow next to you. Don't put it on the bedside table. Drop it below you, because we know that the radiation is actually spread laterally, is also, you know, up and down. So the field is basically so big that if you put it beneath you, you're less likely to get it than next to the pillow.
Well, that's actually very scary because most bedside tables are this
Exactly the same
height as the bed.
And most of the PowerPoint adapters, if you have a look, most of the bedside lamps will be the same height as your bed table. So what you really should do is put your phone in the charger or whatever and drop it on the floor. Put it on loud if it's for the alarm or whatever, but not have it at the same height.
Wow, that's actually very interesting. There's some changes that I need to make when I go back home. All right, so I got time for one more question, and I'll keep it a children's question because it's related to your field. So children are always putting things in their mouth. What can a parent do if a child starts choking on an object?
Okay, so the usual thing we say, simple ABC. If you can't, basically we give back blows to kids. So we put the kid on your legs, and you give basically with the palm of your hand, you hit basically the back. And if it doesn't come out after 5 blows, you turn them over and you do it from the front. And these are pretty hard blows. So we don't do this like you see in the movies, you know, grab someone from behind and try to force it out. We don't do that because you can break the ribs. So the idea is that you remove the object as quickly as you can. If you can't do that, I have seen some people pick up the kid and turn them upside down, like doing a handstand, the idea that it drops to the floor really quickly. But if a child does swallow an object, you know, coin, battery, his hand, go down the wrong way, the first thing to do is definitely go to your local hospital. You don't want to be, you know, umming and ahhing, especially if you think the child swallowed it and he starts having noisy breathing. That's the biggest alarm bell that he's probably swallowed something. He's probably going to choke on it. You need to take him to the nearest hospital.
Okay. I'd like to thank you for your insight on this topic, and thank you for coming on the show.
You're welcome.
And hopefully the audience benefit from what you had to say on tonight's show.
That was a pleasure.
Thank you. And thank you to our audience members who've tuned in tonight. The show is about you guys, so ask in order to know the answer. I'm Mina Ibrahim from your CYC studios in Sydney. Good night and God bless.
CYC, Christian Youth Channel.